Intubating patients with severe metabolic acidosis is tricky. These patients have a compensatory respiratory alkalosis to drive the CO2 down, push that pH up into physiologically compatible levels. When we RSI them, they stop breathing, their tachypnea and hyperpnea go away, and their pH drops off the table. There are some things that we can do though to stave this off and prevent decompensation around intubation. Number one is to minimize or eliminate the apneic period. The best way I found to do this is with a ketamine facilitated intubation. I'm going to titrate in small aliquots of ketamine until the patient's dissociated, no paralytic, which means the patient continues to breathe and continues to have that respiratory compensation throughout the intubation period. Number two has to do with ventilation. We often get through the intubation safely, but then we don't ventilate the patients correctly. We want to make sure to mimic their pre-intubation respiratory status. The best way to do this is to slap on some non-invasive during your resuscitative phase. This helps to relieve the work of breathing, might stave off intubation completely, but if it doesn't, it gives you some numbers. It tells you how fast the patient is breathing and what their tidal volumes are. After you intubate them, you're going to use those for your initial vent settings. So if the patient was breathing 25 times per minute with a tidal volume of 700, those are going to be your initial settings to continue that respiratory compensation and make sure these patients don't have that peri-intubation arrest.